my presentation is going to be way more boring, much worse. Hardcore, no art, terrible. So I'm sorry, I thought I had more than 18 minutes, so I made too many slides. So I have no financial disclosure, so my investment is only in the good of my patients. I have to disclose that what I'm going to talk to you is my opinion on relevance of things, okay? And I have an accent from Colorado. Some of the stuff that I'm going to tell you are going to change our practice, are changing the practice already. Some other can be provocative, so they're not yet ready for prime time, but this is the idea of what we are thinking. So an introduction, briefly, these are the toolbox in blood cancer. In blood cancer, we don't use surgery because it's liquid, right? And so we got chemotherapy, radiotherapy, but most of all, targeted therapy, immunotherapy. The idea is that the combination make the deal, okay? How you make the panino, that's how it works. But that's truly how it is, I'll show you. So of course, targeted therapy, you guys know what they are. Typically, we're talking about pills. They target mutation or changes, and on those mutations and changes, the cancer cell relies on for its survival. Example, obviously, Gleevec, proteasome inhibitor for multiple myeloma, ibrutinib for the B-cell lymphomas. There are certain diseases that actually rely on a common pathway for the cells to become immortal. That's the case of CLL, acute myeloid leukemia, but also other. So where you can use a targeted therapy that is common for more than one disease, for example. That's the example of venetoclax. In acute myeloid leukemia, by the contrary, you have to look for the target. Only if your patient with that specific disease has that specific target, then the patient is going to have a benefit from the inhibitor, right? There are other targeted treatments that have some additional benefits. They can be more immunomodulating. They have an effect on T cell. That's the example of lenalidomide, Revlimid, or ruxolitinib, which is Jakafi. Now, immunotherapy, you all know what it is. That means that there is an immune recognition of the target on the tumor, and then there is a killing of the target. The killing of the target can be made by a cell, can be made by a chemo, or by an immune mechanism or a toxic mechanism. Obviously, as you guys know, immunotherapy, monoclonal antibody. Right there you have your rituximab, obinutuzumab, daratumumab, tafasitamab. Then there are other forms of antibodies, the ones that have chemotherapy attached to them. We call them antibody-drug conjugate, brentuximab, polatuzumab, inotuzumab. These are the examples. BiTEs. The BiTEs are basically immune pieces of Velcro. They put together T cells with your cancer cell. So in many ways are like cuffling. You are cuffing together the cop with the bad guy. That's how you kill the bad guy. And then, of course, cellular therapy. There are medications that can tell the immune system to stop ignoring the cancer. That's the example of the checkpoint inhibitor, PD-1. Anti-PD-1 we'll talk about because of nivolumab. And then, of course, there are the CAR T cells. How fancy are CAR T cells? Are pretty fancy. You got your own T cells. They ship it to somewhere in California, and right there they insert a gene that makes these cells eventually express these chimeric antigen that makes the T cell that direct those T cells against the cancer. Now, right now what we are using in the clinic are CAR T cells that fight against CD19, all these number of CAR T cells in lymphomas, and anti-BCMA in myeloma. And all you guys that you start seeing this stuff done, you need to know that CAR T cell will probably start spread to other cancers, to solid cancers as well. And so one has to be ready for that. Those are newer toxicity. So confused patients that needs to go to the ICU pretty quickly. Another key concept as I bring up some more information, the concept of minimal residual disease. You guys need to know that ultimately, to know that the disease is gone, you want it gone to the last cell. And that's unfortunately what we do. We try to get it gone up to the last cell. to know that your patient is truly in remission, you know that you need an assay that allows you to detect one cancer cell out of a million, which is not something that you can do with a CAT scan, right? Or from lab work, or from a one bone marrow biopsy. So you need technology, and now this technology is becoming available for a lot of these diseases. So a lot of the data that I'm going to present to you are about wiping away minimal residual disease, because the mantra is that if the minimal residual disease is negative, that become a proxy for survival, okay, for long-term survival. And so let's talk about first about multiple myeloma. Multiple myeloma has been characterized December of 23 by clarifying a simple concept. Patient with a newly diagnosed multiple myeloma, patient robust, so a patient he owns a bowling alley yesterday, 65 years old, looking good, untreated. So this patient is eligible for transplant. You know that giving them 4 agents, including an anti-CD38, so subcutaneous daratumumab, is the way to go. So subcutaneous daratumumab plus RVD, better than RVD. This has been well indicated in this paper that was presented in December, published this year. It's called the Perseus trial, was long, and the results were clear as far as progression-free survival. So these patients were, they had need for more treatment much later than the 3. So 4 better than 3. Yet we don't see an improvement in overall survival. That's because we have better and better treatment in 2nd, 3rd, 4th, 5th line in myeloma. Now, I'm going to move ahead because I have a ton of slides. Of course, when you have 4 agents are more toxic than 3. So you got to watch out. It's more expensive, it's more cumbersome. But ultimately, we see that there is an improvement in the outcome of these patients. Same thing for another trial was presented by Francesca Gai that I work with in Torino, where they look at isatuximab, which is another CD38 directed monoclonal antibody like DERA, plus calfizomib, lenalidomide, dexamethasone. Again, 4 agents better than 3. That's all you want to know. People achieve, no, that's truly. So you want to consider that if a patient that is robust is treated with 3 agents, it's got to be a reason, okay? Otherwise, it's substandard. Next, how long we treat these people? Okay, so you give them your 4 agents, then you give them the transplant, then you give them a consolidation, and then for how long do you keep them on a lenalidomide, for example? So this has been a big question. How long? 2 years. You have patients that are in their 40s. For how long are they going to be on lenalidomide? So we didn't have the answer. So the question is, now we have minimal residual disease. Are we going to make a judgment based on that? This trial coming from Spain, HELP, they randomize here people to receive lenalidomide dexamethasone versus ixazomib lenalidomide dexamethasone. And the bottom line that there was no difference between the 2 arms. But what you want to know is that at the moment of randomization and 2 years into the maintenance, they look for minimal residual disease. And what they found is that people that were negative for minimal residual disease, they stopped the maintenance at 2 years. The positive one, they give other 36 months of maintenance. And they found that the people with MRD negative, even if they stop the maintenance, they have better outcome. So this is the first time that we know when we can stop a maintenance. This is the first time that was ever studied in this way. Now, let's talk about past newly diagnosed refractory myeloma. When myeloma doesn't respond, it's bad stuff, okay? Relapse refractory myeloma doesn't play well. These are the data on long-term outcomes on CARTITUDE. So this is CARVYKTI, this CAR T cell. And you see here that response rates are fantastic. Overall response rate up to 100% in these patients, high rate of minimal residual disease negativity, and the response is proven to be sustained, to the point that we have been challenging the concept of giving people, in particular, people that don't respond, for example, to lenalidomide on first line, given whammy of chemotherapy with autologous transplant versus CAR T cells. This study was randomizing exactly this situation, cilta-cel, so CAR T versus standard of care, transplant. These were patients, generally speaking, heavily treated and high risk. And you see here that the progression-free survival was certainly in favor of the CAR T cells. This is to tell you that right now the FDA also approved to use the CAR T cell product earlier than it was before. And this is something that is relevant. You want to know, it changes the practice. So next, in CAR T, in myeloma, relapsed myeloma, we have a lot of discussion about these bispecific. We have 3 bispecific approved: teclistamab, elranatamab, I don't know, pronunciation is terrible, and talquetamab has been approved here recently. Now, the teclistamab had this first trial, was called Majestec. They showed indeed in this patient, we are talking patient that had at least a median of 5 lines of treatment. So those are, you know, those folks that have been coming for years to your clinic, right? 12 line of treatment. Well, in that type of patients, they found an overall response rate in the order of the 65%, 63 to 65%, and there was some durability to that. Those patients, of course, start to develop some, you've got to watch out for the development of, you know, CRS and the neurotoxicity similar to the CAR T cells, because the mechanism is a cellular mechanism. There is now a trial where they're going to be comparing the teclistamab with a standard of care, and it's possible that we'll find out that the teclistamab might be doing better. The study is on. Another study that came up is about this other, you know, subcutaneous bispecific, and these are why I brought it here is just to show you that there are response still in these very heavily treated patients, and these patients actually have a prolonged survival without disease. Another one is talquetamab. Talquetamab has been approved in August of last year, so these are the update on hematology, August of last year, pretty recent. I've seen a couple of people receiving these. It's basically a monoclonal antibody that binds to this GPRC5D and convinces the T cell to kill the myeloma. And actually, the interesting thing about this agent is that it works very well at the same level of response of the other agents that target the BCMA, but has a different profile of toxicity. These patients have less of the CRS. They still have the CRS, but they have some weird skin changes, nail changes. They have different, the taste changes in these patients. Those are things that you want to know about the talquetamab, about the agents that target this GPRC5D. So in our group at CBCI, we've been participating in introducing these medications. And so we had this trial where we gave talquetamab, this newer drug, with pomalidomide in combination. This is to tell you that this new stuff just approved, we are looking at in combo. So this is a very small trial, 2 groups, 16 and 19 patients were studied. The interesting thing, these are heavily treated patients. There was some hematological toxicity, but indeed the amount of response was extraordinarily high for these heavily treated patients. These are patients that you give them pomalidomide alone, they don't respond at all. Adding the talquetamab, actually, we have an overall response rate in the order of the 93%. The same target is now explored using CAR T cells. What if we make CAR T cells against this target? Well, this has been presented at ASH, and about 50% of these people treated with these CAR T cells actually relapse after Carvykti. So these are really patients that are really in trouble, because after a CAR T cell, you don't know what to do next. And they found basically, out of these 84 patients, that there was, again, these off-tumor effect, skin, nail, dysphagia problems, and dysgeusia, right, just like the talquetamab, but the overall response rate was astoundingly high, 88, 91%. We don't have yet data on survival of these patients, but it's actually looking pretty good. Okay, let's move along. I am burning my minutes. So Hodgkin disease, that's what you want to know. In Hodgkin disease, there was this mega trial that said that you can do BV, brentuximab vedotin, AVD, versus ABVD, and there may be better outcome there. well, these outcomes were not really replicated in the older Hodgkin. When Hodgkin happened in somebody that is 60 years old or older, those are patients that have a poorer prognosis. So the people that study lymphoma, not me, they meet in Lugano. It's really cool. North Italy, there is the lake. No, they have spritz. And they talk about this thing all day long, right? So they come up with this Lugano criteria, etc. And in Lugano, they presented this trial where BV-AVD, which is now considered a superior treatment, has been compared to nivolumab plus AVD. They found indeed that there was a in this type of disease was striking the improvement of outcome in nivolumab AVD, and in particular, and this is practice changing. So at this point, nivolumab AVD is what you should consider in these patients. And also looking at the toxicity, you see this is a tornado plot, was actually maybe slightly better than nivolumab AVD compared to the BV-AVD, in particular for example, for the peripheral neuropathy. And here they found that there was, in particular, an advantage in those individuals that are more than the age of 60. So this is another, practice-changing information. Let's talk about CLL a little quick. Okay, there's a bunch of CAR T cells. You need to know that CLL, the first patient treated with CAR T cell was actually a gentleman with CLL. And he died with COVID, but he actually was substantially cured from his CLL. That said, the CLL was not really as successful in getting a CAR T cell. Eventually, though, in March, so a couple of months ago, the use of CAR T cell, and this specific one is the Lysocell, Breyanzi, that, by the way, has been approved yesterday or today for follicular lymphoma, is approved. So we can use a CAR T cell now in CLL. The one thing that you want to know, though, is that the response is not as optimal, like 80%, like in aggressive lymphomas or follicular lymphomas. Is more toward, an overall response rate of 47, 48%. Another thing you want to know is that in December of 23, pirtobrutinib, which is like a stronger BTK inhibitor, has been approved in CLL on all those CLL that failed, ibrutinib, zanubrutinib, acalabrutinib, or venetoclax. These are patients that are very much in trouble. And you see here that there was a fairly universal response of disease to pirtobrutinib. And here, so the overall response rate was 73%, but what you want to know is that most patients achieve a partial remission, a very small proportion actually had a complete remission, and these patients, very heavily treated, they actually had a good progression-free survival. So let's go with aggressive B-cell lymphoma, this laundry list of CAR T cells, and this is just to show you that in second line, in diffuse large B-cell lymphoma, we found, and is proven by 4 randomized trials, that a CAR T cell is better than the autologous transplant. And that is in particular true for patients that are proven to be chemotherapy refractory. Now, something that came up, this is another trial where they compare a randomized transplant versus CAR T cell, and they found that the CAR T cell, the blue line, was doing better. Here they also added this assay called cell tumor, this tumor DNA, circulating tumor DNA assay. This is an assay in diffuse large B-cell lymphoma that wants to be a form of minimal residual disease, because diffuse large B-cell lymphoma is not a liquid disease, it's not a leukemia, it comes in nodes, etc. But indeed, the idea is that this technology can mirror the idea of a minimal residual disease. And the interest in this technology is that when you find in this trial, they compare patients based on the presence of these tumor DNA circulating at 15 days after CAR T cell and 3 months after CAR T cell, and they found that the presence made a difference in their outcome. So this is much more deep than getting a PET-CT in these patients, because still you have people that goes into a complete remission, but you don't know where they are. So this is to introduce the concept of minimal residual disease in these patients. Bispecific, similar to myeloma, we have 3 approved bispecific in B-cell lymphoma. They have terrible name, mosunetuzumab, glofitamab, epcoritamab. Mosunetuzumab is approved in follicular lymphoma, glofitamab in diffuse large B-cell lymphoma, EPCO in diffuse large B-cell lymphoma. And this is a provocative trial where they took patients with diffuse large B-cell lymphoma, they give in 2-R-CHOP. At the end of the 2-R-CHOP, they check whether they have a lot of tumor cell DNA, and then they add one of these newer agents. And what they found is that in these heavily treated patients, right then using these, using this, this cell, this tumoral circulating tumor cell circulating, that you can adapt the treatment in favor of the patient while you're treating. Another provocative idea was to skip chemo completely. So they say lenalidomide, tafasitamab, rituximab, acalabrutinib. So they came up with this all-TRA regimen, no chemo. So the idea is that you take a newly diffuse large B-cell lymphoma. Normally you would give him R-CHOP. You give him 4 cycles of these, and you see what happened. And the idea here is that patients indeed that had complete remission, they just got a couple of R-CHOP, and they continue. The other got more chemo. And they found here, this was interesting, that you had a good proportion of patients that achieve a complete remission with this combination. So can we do it without chemotherapy? It's just a provocative. But once you start adding the chemotherapy, universally you have patients responding to this regimen. So this is great. You see here, progression-free survival flat, overall survival flat. You cannot do better than this, right? Last, and then done, sorry. Acute myeloid leukemia, because it's my specialty, but too many slides. So, to know that FLT3 positive acute myeloid leukemia, if the FLT3 is ITD, you want to use this drug called quizartinib. The reason is this trial is called Quantum First, phase 3 trial. They compare 7+3 plus a placebo versus 7+3 plus quizartinib, and so forth. They studied in many patients, mostly in Europe, and they found that indeed the overall survival was way superior with the quizartinib versus the placebo. In particular, also, you see that you always need an allotransplant, is this FLT3. If you are heading toward cure, that's you do treat for curative intent. Because even if you give the superior treatment, the quizartinib, if you don't do the transplant, you end up like you are receiving the placebo. So this is the idea. You still need to transplant these folks. Next, this trial also showed indeed that the same concept of reducing the minimum residual disease. So we know why the outcome is better, because it's linked to the concept of reducing the tumor burden to 0. Another important and game-changing thing coming in acute myeloid leukemia, this is important because this is going to impact probably up to 30% of our acute myeloid leukemia patients. Patients that carry mutation like NPM1, which is common, or MLL, which is more typical, for example, in ALL, etc. They can use this newer class of drugs. They're called menin inhibitors. They're oral agents. Some, revumenib, ziftomenib, have been explored more deeply. And the idea here is that the data on these agents were tried as single agent in patients that were very sick. And they showed about a single agent, just a tablet, give you a response rate in the order of the 40% in these very sick patients. So what we are doing now, we are actually looking into combining this newer treatment with our 7+3 or with our azaven. The other thing I want to leave you with is that in acute myeloid leukemia, we all use azacitidine and venetoclax. Everybody does that, right? It's easy to do, etc. So azacitidine and venetoclax is basically becoming kind of your bottom line, the backbone of any combination. So what when you add more agents? So the first thing, just to let you know, is that they presented data that if you, instead of using the cytabine IV, you use the oral form of the cytabine, gives a little more GI symptoms, but actually works as well. And just like the cytabine is 5 days in the clinic subcutaneously or IV, this is 5 days by mouth. And you can do it. The cytabine I believe it's called Inqovi. You can, right now, based on this data, you have more ground to use it with venetoclax. So you can consider inducing your patient at home, right? So it's pretty cool. Now, when there was all this hype about doing an all-oral treatment, then they started to say, what if we add a third agent to decitabine and venetoclax? And here they added a menin inhibitor, one of the drugs that I just discussed with you before. And they came up with this study. They gave these names kind of lousy, SAVE, the SAVE trial. So who doesn't want to be on the SAVE trial? Yeah? So revumenib, decitabine, venetoclax, all oral, right? And the cool thing is that these are only 9 patients treated, so it's not like 900 patients. But the characteristic of these is that these were patients that have very serious disease. They just got this all-oral treatment. And the report is of an overall response rate with complete remission, actual complete remission of 100%. So this is pretty potent stuff that the patient has been taking at home, right? And of course, these patients are still patients that are cytopenic. They need to come to clinic multiple times a week. You know, some of these patients have hospitalization, but still is very provocative. Another thing is we have other oral agents already available. Why don't we add it to the decitabine venetoclax? That's what's done using the IDH inhibitor, ivosidenib and acidenib. And so they came up with a schema, and they found that 3 drugs together. So here the treatment are a handful of patients, but basically the response rate was almost universal. 96.2% of these patients achieve a meaningful clinical outcome. I move ahead faster. The last thing I want to show you is that you can also, we have been using venetoclax for a while also with chemotherapy. At least I do that in my practice, makes patients significantly more myelosuppressed, more sick. In Germany, they came up with this regimen called, they call it relax trial. So how relaxing is that? But to use mitoxantron and high-dose cytarabine, so stuff that we have been using plus venetoclax, and they studied a group of patients that was, you know, very, very heavily treated, relapse, including relapse after transplant. They gave this schema, fairly simple schema, 14 days of venetoclax, cytarabine, mitoxantron. Here, 38 patients were treated, and indeed, there was a certain number of these patients that got an allotransplant. The majority had adverse effect, adverse cytogenetic stratification. They found that the risk of mortality, because this is the risk in this patient, is they may die soon. The 30-day mortality was 2%, 60-day mortality was 5%. You know, something that unfortunately in this situation is considered to be acceptable. So was overall described as well tolerated, but indeed the response rate was very high. So where we have a lot of patients achieving a complete remission and a negative minimal residual disease, that means that this patient, like happened in this trial, could be considered for a transplant again or even a second transplant. With that, I'm sorry the duration of this, and thank you so much.